I'm Jonathan Wick, Vice President of Healthcare Industry Insights from FinThrive, and I'm joined by Miguel Vigo, the Chief Revenue Cycle Officer at University of California, San Diego, UCSD, and we're here to talk about the NAHAM conference, and as well, we're going to talk through something called the Revenue Cycle Management Technology Adoption Model, or the RCM TAM, and how that can help set strategy. Welcome, Mike.
Thank you, Jonathan. Great to be with you, and I'm excited to talk through the
Cool.
RCTM product today.
That's awesome. All right, we're going to dive right in here. I'll advance these slides and we'll walk through. As I mentioned, we're going to talk about the RCM TAM today, and we're going to walk through just where we're at with some market things. I'll walk through that, and then we'll hear about Miguel's organization out there at UCSD and what they're doing, and then we'll talk through this RCM TAM. And then look at some KPIs and some other things as we go. I wanted to start and set the tone by recovery, not the PACU type of recovery or surgery recovery, but just financially where the market's at. And I'll show some numbers and where we're at. I think last year was mostly a year of recovery. We'll hear from Mike here in a minute about how California did in his organization, but really was a year. I'm a big Kaufman Hall fan. This flash report comes out every month. You don't have to be an econ major to understand that it's going to take you at least as long as your deficit to come out of it. We've got kind of this propeller or windmill pattern here. If you look at this in aggregate, we're running right around break even now. I actually just pulled this report up for January, and it's running about 1.8% in aggregate for most of 23. So finally outpacing a little bit of the deficit that we created. I like to call that margin compression of the result of what I call the three-headed monster. The first head of that monster really is patient volumes. This isn't a strip from an EKG. It's actually emergency inpatient and outpatient volumes that we track here at FinThrive, and they're there in those respective colors. And you can see, the trough that occurred about 3 years ago. Believe it or not, here in a few short days, if not now, we're celebrating the 4-year birthday of COVID. It certainly caused a large trough of activity in terms of just outpatient procedures and lockdowns and those types of things. And then that leveled off in 21. And then we had kind of this similar pattern occur over the holidays, Thanksgiving and Christmas, are what those low troughs mean on the outpatient side. That makes sense. A lot of people don't go get surgery, instead of turkey dinners or Christmas trees and those types of things. Nonetheless, what I like to find interesting is that inpatient ED has really stayed under normal. That 0% mark there that's hashed out as below normal. We haven't seen inpatient and ED volumes recover fully. Inpatient's kind of peaked up just a little bit there, you can see, but that dark bar of ED volumes are there. And we can get into a whole nother talk about why we think that is, but I think, telehealth and I think self-care and just, basically outpatient type care has kind of taken the seat of that. But most hospitals I talk to, we'll talk to Mike here in a minute too, have indicated that their volumes are mostly back, but ED is still a little bit low. And as a function of that, so is inpatient. We'll walk through as we go. This is what I like to call the alligator chart. And this is a JOLT survey. JOLT stands for Job Opening Labor Turnover, and this comes from the Bureau of Labor Statistics. I just like showing this as the other head of the three-headed monster, why margins are there. Before COVID, we had relatively stable, hiring and opening trends. That top bar is openings, that light blue, that orange is hires, and there's always kind of this delta of about 500,000 positions. That makes sense, right? If you look nationally, there's always going to be more open positions than those that are actually hired. Well, COVID came, disrupted that. We had to hire immediately to kind of handle those spikes of the Delta and Omicron, and then kind of went back down to a normal level of hires. But the openings kind of skyrocketed. And that gap has pretty much stayed there for the past 2 to 3 years. And it's a pretty big delta, 1.3 million open positions. And a lot of that I like to call are mic drop type positions. It's people that are just like, I'm out. I didn't sign up for this. I'm switching careers. Nursing and clinical positions were already somewhat fragile before COVID happened. And I think this was the straw that broke the camel's back. And even if you wanted to hire all of your positions, I think you're going to start looking at technology and just different staffing models as we move forward. And I know that's the case at UC Davis or UCSD as well in San Diego. They're definitely different ways of delivering care than what we delivered 4 years ago. And we're having to be more efficient. We can't pay for contract labor, which was one of the main reasons clinical labor was one of the main reasons why margins suffered so much, as well as volume. And then, of course, our favorite, the payers, they are playing some really big games of hardball right now in terms of their activity. Denials are running right around 4% right now for write-offs, very, very high. Staff time in terms of complying with policies. This is an AHA survey, is showing very, very difficult relations in there, and they're saying that it's getting worse. Most of the hospitals I talked to, Mike joined us at our FinThrive advisory board here last month. There's just a raw disdain of hatred for the payers right now. I haven't seen much love in that area, and I think we'll get there someday, but it hasn't been good. As I mentioned, denials are running right around 4.5% or 5%. This comes from Clarivate or HBI data. That's the write-off rate, gang, too. That's not the initial denial rate. I would have gotten fired when I was a chief revenue officer if I had a 4.6% write-off rate, 10 years ago. It seems to be the norm now. Benchmark performance runs anywhere around 1%. But I'm going to turn it over to Mike now. Just initial thoughts on what's going on in the market, and then we'll talk about UCSD as well, Mike. But what are your thoughts on those stats? Is that ringing true in California, or there's some other things going on there?
It's thank you, Jonathan. I think the one thing we're seeing in San Diego a little bit, we might be out of the common, I guess, nomenclature here, is our ED visits are still pulsing pretty high, but pretty much everything else has definitely been there. I'm not sure. We don't have a silver bullet or full understanding on the ED part, but all I know is we've got volume, we've got a good problem, and we got to figure out enough beds or the right place of care for them. So good problems they have, but problems nonetheless. So
you bet.
Yeah,
I'll advance the slides for you, brother.
Yeah, very proud to be here, and thank you for having me. UC San Diego Health is a part of the UC Health Network based off the university system throughout the state of California. We're fortunate that we offer pretty much every specialty and service out there, not just for patient care, but obviously being part of an academic center, we have a lot of school education and training, which we represent either for the 50% of what's offered in California, or we're the biggest organization to offer that. So odds are it's a few degrees of separation from somebody you know that's either worked or been educated through the University of California system. So it's really, really great system to be a part of. More specifically, on the next slide, you'll see for University of California, San Diego, we really have 3 main hospital campuses now. That recent acquisition of what used to be called Alvarado, we call it East Campus, is part of our newest growth initiative. And we continue to reinvest in all of our current facilities, including Shiley, our cardiovascular center, our family ortho outpatient center, and our Moore's Cancer Center, just a few to note that we work with, we provide care for, but also on the leading edge of research. We're based in the south part of California in the San Diego County. So we pretty much go all the way from what's commonly called North County, kind of Oceanside, Carlsbad, San Marcos, and we go all the way down pretty much right up to the Mexico border. And here's a little bit of a layout of where our main hospital campuses are with satellite locations through all. It's very important to note that outside of our medical and our healthcare practice, we really do have a mission, vision, and culture to care for everybody every day equally across our system. Can't do so if we don't have the money and funding to do it, right? There's gonna have a beautiful mission statement, but if you don't have the money to support the mission, then it's a mission that will die pretty soon and fast. So about 3.7 billion of our net patient service revenue, and a lot of our statistics there. So we're fortunate to touch almost every life in the San Diego County region in one way or another. We don't do so without making sure that we take care of not just everyone that has the needs, but whether you have the right means financially to come to us or not, we want to make sure we're taking care of our community in every way we can, whether it's a homeless patient, a patient that just came into our community or into our country, or if it's somebody coming on hard times. I believe San Diego was recently rated by the U.S. News and Report as being the most expensive place to live. Hashtag I could use a raise. But it is something that we make sure we reinvest in our communities and take care of our population, no matter what income or financial background you come from. So proud to be a part of that as well. The other part that makes us very special is that we continue to keep quality and patient safety top of mind. For the second year in a row, we were rated #1 in San Diego, beating out a lot of our competitors. But also, we were recently ranked 5 stars from CMS, and we're on the nation's honor roll, meaning we're in the top 20 hospitals in the country. So not just financially taking care of our patients and doing well from our revenue, but also making sure our quality goes alongside that as well. So very proud of the organization and the quality we bring to the community. So a little bit about revenue cycle. What are we doing to help support the mission, the vision, the values? So there's a number of pillars that go into any organization. And as I kind of joked about earlier, but in a more true statement, we want to make sure we're supporting that mission. We have to have a strong financial foundation, and that financial stability and sustainability comes in a few different ways. Cash and AR management being the biggest parts that I'm fortunate to oversee with my leadership team. I'm going to show you a few things that we're doing to help support that part of the pillar and that platform. A little bit of how we do this, broken out our org chart. I have a fantastic team of folks here, but more importantly, we lead and break it up by what makes sense for our operations and our teams and our community. We continually review this. I just mentioned we had an acquisition a few months ago, and we have another acquisition coming up again. So we are not afraid of tradition. We are not afraid of new and what's coming. We will shake things up to make sure that our teams are split up in a way that supports both the patient, the operation, but also our employees. So love my team. This is my org chart here, but as we continue to grow, we're always looking to redefine our team and how can we be even better. So how do we do that? So we want to make sure that we tie all the way from the top part and our mission, vision, values, our strategic goals for the year that align from every single team, whether it's strategy, whether it's physician care, financial investment, whatever that is. And we want to start cascading those down. And how can we tie that together? So one way is making sure we're setting objectives. The other way is how am I setting those objectives to make them measurable and obtainable? What resources and tools am I giving my team? And then if I need to put a KPI or metric there, then we're doing that. So we're tracking it. I will say that at a director level, we set them at a level that's easily explainable to our non-financial teams. We also break them down into subsets so that every team has a hat in the rink, if you will. They want to make sure that they're contributing to it. It empowers them, makes them feel good, and then it supports that larger goal. That way you drive the engagement from the teams and you give them something to look at every day that they can achieve, measure, and know how well they're doing. So how do we break that out? We try to make it as simple as we can. We talk about what can we control internally? What's a process that we have that we can look at, whether it's ordering things, our contracts, how are we spending our money and our budget and our resources? If it comes to our financial perspective, so how much cash are we getting in? What's our cost to collect? What can we do to add a few more codes and modifiers? How can we further support not just gross revenue, but net revenue to make sure that we're moving forward and supporting the financial incentives? Customer perspective, our patients are #1, our main customers, if you will. So we're always looking at patient experience and engagement scores to keep supporting them in the care mission. And then lastly, what am I reinvesting into my teams? I say lastly in the management of order, not in the management of priorities. So what am I doing? Is that more town halls? Is that setting up safe to speak computer learning? Am I making sure that they have multiple outlets to work from and communicate with? We really want them to feel like they're empowered and they can get joy when they come to work and the work they produce. A couple of examples, these are kind of the high level executive examples that we report out. Our net collection rates, essentially all things collected with our contract and our payer contracts and what we expect to collect. I am fortunate to report that looking at Mr. Wick's graphic a few minutes ago, I am just ever slightly below the national average for write-off on the hospital side. The physician side, the metrics a little different. They're a little bit tougher, but still doing better than most in that national average. So very proud of that team, but definitely room to improve. That denial rate, unfortunately, continues to be something that increases as we're seeing across the nation. I'd love to say that we're getting closer and about to sing Kumbaya with our payers, but I'm also a realist. So I'm going to tell you that that's not true. So what can we do to get a better internal look of how we're doing so we can change things and get more efficient and continually and readily adapt with the changes that come? And then lastly, our age. I think I'm not going to tell anybody here anything new. The older the account, the harder it is to collect. So that's always a metric we want to bring down and get closer to have a fresher AR. How are we doing this? Well, Epic first, that's our EMR. We always want to invest to get our features, functionality, whatever we can do. If there's any type of new development or organizations or providers want to test things out, part of being an academic, we raise our hand first. We're not afraid to be the first person, the beta partner, alpha partner, do the research. We always want to do that. So we're always looking at automations and Epic Tech first. ABN, we're one of the first organizations in the country where we actually have hard stop the ABNs all the way from ordering down. I can tell you that monthly we are saving hundreds of thousands of dollars, and that is pretty new for us. And yes, there were a lot of folks blowing up my email and my voicemail, but we have worked with them, we've educated them, and we've handheld those departments, but we're continuing to do really, really well as we roll out that ABN optimization. Denials prevention team, nothing new there, just looking at different ways and intaking data. How can we slice this differently, reprioritize accounts? Our vendor contracts is pretty interesting. I've only been at UCSD for about a year and a half, but a lot of opportunity there. And I think when you start sitting down and talking with your partners about how can we really drive what's best and get top of license performance out of both, your real partners will stand up. They will meet you there, whether that's a rate discussion, a cap discussion, accountability discussion. That's something that really is important. And you really find out who your best partners are there. So that was a big learning curve for me here with our partners at UCSD, but it's also been one of the most educational, as I've learned a lot about how we can perform even better. Financial experience is number one. How can we make it easier for patients to pay their bills, make it easier to understand? And that also works on the vendor side too. How can we streamline this so I'm not spending X amount of FTEs researching invoices? So make that entire financial experience, both external and internal, a bit easier and better and streamlined for all parties involved. And the last part, I'm kind of repeating automation, but this is really external. How can I use either my own internal software designers or my partners to push further so that I have these automation solutions, even if my EMR is not there? How do we do this? How do we track this? Sounds like a lot. Trust me, this is only a snippet of what we've got. This is probably a 13 or 14 megabyte document that we run, but we've got a great leadership team and a project management team that helps us keep folks accountable to how we're doing, kind of Gantt chart it throughout the fiscal year, what's at risk, what resources are needed if we need to reprioritize. And we do that with some internal scoring, but it's a very detailed map that we keep, and we politely but aggressively keep everybody accountable. And we meet every 2 weeks to go over this project document and make sure that if anybody needs anything, they can voice that out, they ask the questions, and we get them what they need. Or I'll be real with you, as I mentioned, we will reprioritize or decide maybe that was a priority in October. It's not so much anymore because we bought a hospital. So we continue to look at this. We don't push things just to push them. We really do a lot of deep breath checks to say, does this still make sense for our mission? Does this still make sense for our strategy roadmap? And if not, we're not afraid to cut it. If we fail at something, we learn from it, we move on. But a little snippet of what we're looking at this fiscal year. So how do we get better? I think that's the one thing with rev cycle, right? It's a circle. So we're always being asked kind of the same questions. How can we continually be better? Well, we'd love to, and we do this well, we would love to be better. We partner with our contracting team. Right now, we've been kind of put to the limit twice with terminations with Aetna and Anthem. Two of our top 4 biggest payers, Anthem, Blue Cross being our top one. We took it all the way to the poker table, all the way to pretty much the final hand. And let's say that we called the bluff and we won that, right? So in an area where it's very tested, I can tell you that, trust me, there are some winning cards up the sleeve from a provider standpoint. It's on how you play them. Unfortunately, when we don't always win them, there's arbitration and litigation. I really hope a lot of you have not gone through this as much as maybe we have. but it is a realistic strategy you need to start thinking through and putting together. You can plan all day long and you might have a contract black and white. That does not mean that they're going to abide by it. I'm not telling you anything new. So you really got to think about how you want to approach that internal, external, and your data's got to be solid gold in order to move forward with whatever strategy you put forward with. Another items are payer mix. Medicare rate increases, if you call them that, have not been the most profitable or at least beneficial to us. So we got to think about different ways to cut our costs. And the last part is those are things we can control. There's things we cannot control. Inflation, economy. California just had a wonderful law come through that makes the minimum wage in healthcare $25 an hour. That was not in our budget 2 years ago. It is in our budget now. But those are things that we really are outside of our control and we have nothing to do. But we have to figure out how can we continue to be more efficient, use automation and technology, because that cost cutting is it's never going to stop, right? And rev cycle is usually one of the top areas they look for. So just thinking outside the box with some of these things.
All
So
right,
what have
thanks.
we done? Oh,
Go ahead. Sorry.
so what have we done from a market standpoint to look at how can we get some information, get some partnerships, so we're not acting in a silo, but we're also looking to take a real self-health check of how are we doing, where are our biggest opportunities, and where do we really need to invest our time and resources. So we had a need, and luckily FinThrive was right there. So Mr. Wick, I'll toss it back to you.
You bet. Thank you, sir. We're going to walk into just some specific things for revenue cycle. This has a QR code here. You're welcome to click on it. It will launch the 2024 Transformative Trends Survey that talked through about 92 executives like Mike here and their perceptions. And we asked pretty simple questions just to understand what's going on in the market. What are your priorities? If that is a priority, how are you going to tackle that priority? What technologies are you going to invest in and those types of things? And this shows really some interesting statistics just between last year and this year. Just revenue as became somewhat more important than it was. I think it's always important, as you heard from Mike. Patient experience switched positions. It used to be in kind of the third position under cost, and based off those statistics I showed you earlier, a lot of organizations, including those in California, were really in a spot of cost control. I think you're always there, but that dial kind of gets turned up and turned back down depending on how you're doing financially and how those margins are performing. Once you get your volumes back, you play some good poker hands, like Mike said, in terms of your payer negotiations. You manage your denials and maybe get some more revenue captured through your ABN and Medicare processes and things like that. That allows for you to maybe put patient experience back up. I think these are always important goals. It's just important how they stack rank them. What's important now is financial leaders are absolutely looking for a way to chart their course forward. They have health systems are contracted with more than 40 vendors as they go forward. And this footprint really, examines what all those things are. This was something that I certainly had when I was a revenue cycle leader. It allowed me to kind of understand what solutions I had and what I didn't. Before we even had an RCM technology adoption model, it was more of just a checkerboard, if you will. And do I have that? Do I need that? Can we invest in that? What's that plan look like? And it's arranged kind of front, middle, back. We call this kind of a placemat, but it's not unlikely to have, a couple dozen, if not 3 or 4 dozen different solutions that are either embedded within the electronic medical record, or they're a third-party bolt-on solution, or an end-to-end platform like FinThrive that allows you to manage your revenue in a way that's not leaving any dollars on the table. Common concerns from folks like Mike and others are, what is inside my core EMR? What do I have from Epic or Cerner or Meditech or Allscripts? What technology do I have on that placemat today? As you transition organizations or any different organizations, what is my total cost? What am I spending? What's the yield from these solutions? How are they doing end to end in my organization? How much am I driving my IT department nuts? They were my best friends when I was a revenue cycle leader, because I constantly had to ask them, for new secure portals or new VPNs and get their teams together in terms of making sure we had the data and things that we needed. What is my path? How can I automate? You heard Mike mention that as well. How many vendors do I really need? The performance has been difficult to measure, expensive to maintain, and I would argue duplicative in offerings in the past. And every hospital, and you heard it from Mike and his strategic objectives, they absolutely are looking at what's core within Epic, what are some automation technologies they need to have to manage my denials, my other contract management, insurance discover, all of those things that I need to do to capture revenue. So we're going to talk about the revenue cycle technology adoption model here, and Mike and I are going to kind of go back and forth a little bit on his results specifically. This is another QR code that you could click on that actually will launch the survey for you. And you can take that, as Michael will elaborate on here in a little bit. Sometimes it's good to just set time to do this with your team. So you certainly could take it alone, but if you, my recommendation of what we've seen kind of as a best practice is, click on this QR code and set a hour meeting with your team and walk through, because you'll learn as you go that it gets pretty granular in terms of what's there. And it's nice to have some of your experts that are over those parts of the department help fill it out. How the model worked, or where it came from, is we really went and surveyed 100 organizations. And what I want you to remember about the RCM TAM are two things. Is the technology valuable in the market? We used a 5-point Likert scale. We'll go over that in a minute. And is it something that's really not useful, or it's mission critical? And that really helped us establish, what technologies are valued in the market right now from a use standpoint. And then secondarily, okay, that's great. And Mike will tell you this too. We all wish we had $1 billion budget, right? There's technologies that are out there that you absolutely think are valuable, but you may not have them now, depending on your financial position and what your budget looks like. Mike mentioned the cost pressures that he's having from labor because of California statutes and those things. It's in the budget now, but it wasn't. And as much technology and resources and people that you want to invest in, there's always seems to be this gap, just like that gap I showed you between hires and postings, in terms of what you want and what you can have, and what are nice to haves and what are need to haves. We wanted to represent all the EMRs, which you could see there. We also wanted to represent different sizes of organizations in terms of beds and their net patient revenue. So as I mentioned, there's two things that we measured in here. Was the technology mission critical, or was it of no value? We removed the things that were below moderate, low, or no value from the model and just kept the mission critical and high value. That'll be a theme that we walk through here. And then we looked at stages of these into 5 different levels in terms of, is this in place in more than 60, 70, 80%, and so on of organizations? And as you'll see the model here in a minute, it walks through that. So this is the model, and we'll get into Mike's results here in just a minute. And, basically, talks through broad, high, moderate, and emerging adoption levels. And you can see those color codings of that 4 or 5 mission critical or high value types of levels there. Obviously, things like eligibility, claims, I would argue estimation, some of those things are absolutely things that you have to have that are mission critical in any revenue cycle that are there. You'll see different levels of penetration as we go forward here. But to move from one level to the next, really need to have this 70, 60, 60%, level of adoption to move in stage by stage. As we looked at those stages, we saw a V-shaped type presentation come back. So 5 stages presented, about 43% of the market's at stage 1. They've got 50, 60% of those mission critical or high value solutions that we talked about. About a third or so are in stage 2, 8% there are in stage 3, and then 4 and 5 really are kind of these aspirational levels. If we remember the EMR adoption model that came out during Meaningful Use from HIMSS, this model kind of took some of those things from that and wanted to really look at, that one has a 7-stage model, if I recall. And if you recall, stage 7 might be that you are sharing data between facilities across states as patients transition to different levels of care or maybe travel and those things. And maybe stage 1 or 2 had computerized physician order entry or maybe electronic charting, those types of things. There were federal dollars attached to this. Don't we all wish there were federal dollars attached to some of our revenue cycle technologies? Nonetheless, it's a 5-stage model, and certainly the breadth of technology is more saturated as you go through those levels. Here are the stages, and in a minute we're going to go over what Mike had. But as I mentioned, 1, 2, 3, 4, and 5, and you can see, as I mentioned, 43% were there at stage 1, and so on as you go left to right. And we looked at those results and also measured KPIs, which I think was something that's very, very important. These key performance indicators, these aren't all of them, but big five, you saw some of these similarities in some of the things that Mike was measuring. Point of service collections, AR over 90 was something, denials rate was something he was measuring, cost to collect and bad debt. Those that had a higher level of technology had a higher level of performance against these KPIs. And that makes sense, right? I mean, as an organization, you invested in this technology, you shouldn't be paying for it or continue to pay for it if it isn't moving the needle across some of these KPIs or all these KPIs of the organization. So the purpose of kind of showing you this is those that did invest had better financially performing revenue cycles than those that did not. So this is Mike's here, and compared to your peers, where did you show up? And UCSD, basically before he even took the survey, Mike said, "Yeah, I bet we're in the middle." And Mike, do you have thoughts on this slide? And when you first saw the survey, what were your initial impressions?
Yeah, I think it was thinking I was right about in the middle. I'm not going to lie. I think we'll get into it a little bit. I thought we were a little bit further along in some areas than we were, but
Yeah.
nothing resets you like the truth. So after going through the model and going through the questions and talking with the team, it really did bring a lot of reality and resetting of priorities for us.
You bet. This is Mike's results, and he came out, I believe, as a stage 1, if I recall, and that's the majority of the organizations, and he's going to, I think, quickly move into stage 2 based off of some of those investments, and even into 3. And it doesn't take a lot to get there. And the idea isn't necessarily to advance through all the stages as fast as you can. As we're looking at this is just to expose you to the model. There wasn't one. As we started with when we were talking about revenue cycle market approach, there really isn't a model until now. We've partnered with HFMA on this model. It's on their website as well. And when you clicked on that link before, it should take you there. And HFMA has looked at this. Sean Stacks, a colleague of mine over there, has looked at it as well. And he thinks this is great. It allows you to kind of understand what pieces of technology are out there, first and foremost. Secondarily, what the rest of the market thinks they are from a value standpoint. And then also allows you to see from a deployment standpoint where you're at. You can see where Mike check boxes and X things. And one of the things I remember, Mike, when you first did this is that you filled it out and then you met with your team because there were some differences in what your team felt you had from a footprint standpoint and what you felt you had. Do you want to elaborate on that a little?
Yeah, so I mentioned my time with UCSD being about 1.5 years. So came in, did initial discovery, kind of exploratory work, had some great impressions, looked at some data, and that happened to be the time I took the initial assessment or intake, and was walking away feeling pretty good, definitely feeling like I was 2 going into 3, if you will, and then was able to circle back with my team, had them walk through and complete the same steps. And that was a bit of a reality check, meaning that my perception of where we were at from a tech standpoint was further along than we actually were. Now, that doesn't mean that everything was on fire, but it definitely helped me reset and re-understand where we were, where we had maybe done an initial investment but hadn't seen it through, or to Jonathan's point, in a couple areas where we had made some investments and it was not getting the ROI, the expectations we had assumed or thought. So definitely reset reality for myself and my teams, and helped maybe a beneficiary of this tool and the expected outcomes, but it really brought us together and use it as a platform, a lot of discussions that we were not having because others were seeing their realities come to light as well, or their perceptions be reset, and allowed for a lot more engagement and collaboration, not just with myself, but with a lot of the leaders as well.
Cool.
KPI. Yeah, so one thing.
Go ahead. I'm sorry. Yep, go ahead.
No, go ahead.
Yeah, one thing I think was interesting here too, Mike, we'll certainly spend some time on this slide and this is one of my favorite parts. And I remember when I was a revenue cycle leader, and I know you're a revenue cycle, I like calling ourselves gurus instead of geeks or nerds, but like we really love numbers, right? And I love to be able to see, like, is this a we problem or a me problem, and being able to understand where we are. And one of the beauties of this is it's a database that's learning. So as more people fill out the survey and do an assessment, these KPIs that are attested in there start to get hardened and more concrete. by each level. And you could see how you performed as an organization against maybe a stage 4 or above organization, to that point I showed earlier about how investments in technology really should drive an ROI. And Mike, I'm going to ask you some questions here, but really doing well in areas like point of service collections, AR days, denials, as you mentioned, cost to collect days cash. Those are some opportunities, it looks like, in terms of for your organization. Clean claims and bad debt look like some areas that you might have some opportunity as well. But what was your thoughts as you're looking at these KPIs and understanding where you're at, and what are some areas of focus?
Yeah, really just more real time or front end assistance.
Yeah,
So point of service is an easy one, but of course,
right.
clean claims falls into that.
Yeah,
A lot of the AR work, I think we spent a lot of time touching accounts longer than we should or retouching them. I also think that we probably deprioritize a large subset of accounts because we're like, oh, those will easy, I'll get to them later.
yeah,
Um, and on those categories, I definitely saw this tool highlighted opportunities where we could use tech or some sort of hybrid combination. Not that they're not important, because to argue the point, they probably aren't the most time sensitive or most complex. But if there's a technology that can accelerate those, automate those, or batch job and whatever the scenario is, then why are we not doing that? So those are a couple areas where, yes, we can work them. Yes, our overall net collection rate's good, but like you were saying, cash is still important. How about we get that cash 10, 20, 30 days sooner instead of having to touch it multiple times, or we're just putting it on the back burner. So that was something that really came out from the results, and seeing not just the stage we're in, but if we really progress through the stages, immediate cash benefits and acceleration.
awesome. And this is what I like to call the jelly bean document. I think the business has a different opinion, but I like calling it that because it does look like a box of jelly beans. But it really is nice. On the left in navy there, you see the work streams, and then there's a color coding of things that are mission critical or of high value, which you could see there in the upper right corner from the legend, the kind of blue and the light blue. And then things in gray are things that you already have. And so I love this because it's kind of an at a glance. Okay, if there's a lot of color on this, there are things that I need to look at. If there's a lot of gray on this, there's a lot of things that I already have. And there's kind of a combination here, isn't there, Mike? It looks like there's some things that you can kind of look at the work streams and understand which ones you want to prioritize or not, which we'll get to in the next slide. But do you like this view, or what are your thoughts here?
No, it's great. It actually takes kind of the generality. So the last update I gave was a bit more of a exact high level. The next layer of that is, well, how are you going to do that? And I think that's where this one really steps in and says, well, these are the key areas that we need to focus on. And this is kind of that direction setting with your management, your leadership team of, we need solutions or a hybrid approach or some sort of strategy to attack these colored items, because these are the ones that are going to help drive where our KPIs are not meeting.
Nice. And then it allows some areas of priority, right? And so you had already mentioned this, but scheduling and pre-reg there got shaded. Going to look at optimizing the strong work that you've already created foundationally in ABM, but adding some tech there to help. Insurance discovery, I know, is something that we're working on with UCSD at the FinThrive level in terms of just finding other coverage that's out there and piloting that at one of your sites that you recently acquired, and then expanding that out to others. And of course, everyone's favorite, prior auth. And then denials and automated appeals was something else you wanted to focus on. And you had mentioned some of the areas that were priorities for you, but the technology here is something that's going to benefit UCSD. And how do you feel this helps when you're looking at investments to understand where you're prioritizing?
Yeah, I think a couple of things. One is the immediate, the cash impact timeline is important to measure as you go through it. But more importantly, we have some issues where, you know, how are the timelines to get these solutions in place? Not just the cash timeline, but for example, an authorization, automated prior authorization, super critical, super important. You do not want to rush that. The plan level, tying and mapping, super important. A lot of time, long road there. Remittance manager, maybe some claim statusing. Not that those aren't important, but that roadmap is a lot shorter of one. So that's one that you kind of want to get all the plates spinning at the same time, if you will, but understand what resources are needed here and which ones can I schedule so that I'm continually having these cash influxes, or at least the projects that are supposed to lead to those in sequential order, so that you're continually having success and you're not overextending your resources and your team, whether that's operational or it's your IT EMR partners.
Awesome. Yeah, this gets at that timetable. I think I like this view as well. Nothing would make my CFO or my finance team happier than having this, from me in granular detail, on a month-to-month basis, right? You just don't have the time to do it. But from a technology standpoint, it's nice because you can budget off of this. You can set revenue targets or goals. And I know UCSD is a very metric-based organization based off what you showed, Mike, but I love this because it allows you to see, okay, these are mission critical things. These are high value things. These are the years we're going to work on them. And you could, one, hold us accountable as a partner, and you hold yourselves accountable too to delivering on the technology to move those KPIs as you talked about. This has about a 12 to 18 to 36 month timetable. And how are things going here? You've started some of these, right?
Yeah, we have. Things are going pretty well. I think the ABM medical necessity one's been a little bit of an immediate keeping cash in our pockets, if you will. We're definitely doing some claim status and charge capture reviews. A lot of opportunity there. However, that one takes a lot more manicuring or curating, if you will, especially at an academic institution. But a lot of the what I'll call lower hanging fruit, the claim statusing, some of the scrubbing of the accounts for additional coverage. Are we looking? We have a lot of data, to your point. Are we slicing that, looking at that in the right way, and putting it through the right partners' engines to see what opportunities there? So far, all of this is going really well. To be honest with you, Jonathan, I just wish I had more hands on deck to help provide and do the slicing. But that goes back to the budgeting thing, and I don't know if we want to talk more about that.
Yeah, don't we all? Yeah, so this is your slide, Mike. I'll turn it over to you, but these are just general impressions that you have from the model. So I'll let you walk through these bullets, and then we'll sum it up here.
Yeah, I think it's important to point out, I'm not sure if you're going to talk about this in a second, but it really was an unbiased, there was no input in terms of, swaying the conversation one way or another. It really was just an intake, and it was easy to understand, easy to walk through, was not a huge time suck at all. And the questions that were a part of this and the steps made it easy to understand. And you almost, as you're answering them, know that, wow, this is asking very direct questions that you might get some version of them in other assessments or conversations with consultants, but it's not really getting at what your problem is. As a provider, we know what our problems are. We need help, and how do we attack it? So the questions that came through the tool immediately got my attention. So I was excited from day one. I think I talked a little bit about being surprised and a little bit with the results that came through after the team were engaged and involved. I think what it did, as I mentioned, kind of level set us. But what kind of happened after we got going and putting all the data in from all the team and doing that second review was there was a moment where I went to go talk and somebody spoke over me. And then I was going to respond to that and somebody spoke over me again. And instead of being an ego, which I'm not, but instead of letting my ego get to me, I just sat back and I took a deep breath and I watched the leadership team come together. I watched them have subgroups and let's do this and I can do that. And what about that? Let's grab coffee on this. And as a leader, especially in rev cycle, especially in the day we're in, it was one of the sexiest things I've ever seen because my team was taking this tool, using as a platform, not only for metrics and strategy resetting, as I talked about, but it started bringing them together of how they're going to tackle things and how they're going to measure their success of as they move forward with whatever those solutions and those next steps were. So this tool was not something that just enabled me to have a better landscape of what's happening and how to move the pawns on the chessboard forward so we can get to a success. But I didn't have to do that. My teams are doing a lot of that. And I think at the end of the day, that's really what we want. Because yes, my name is on the end of it, but I don't succeed without them. And they're the ones who are accountable for it. And this tool provided that transparency and that collaboration. So that dialogue, that accountability that came from that, that's something we all want, we all push for, but we rarely ever get consistently. And this tool set that platform. So I was very impressed at the beginning. And I walked away from it with way more positives and wins than I thought I would.
Awesome. Well, I'll wrap us up here. we need to embrace disruption. I think Mike has mentioned that with his team. The volumes, are there in California, but I would argue across the country, California's kind of its own unique market, especially the San Diego area. Negative margins are still present. I think we're going to continue to see continued cost pressures and supply pressures and payer relations. Financial leaders will need to establish a vision, and you see that from Mike and his team at UCSD, and I think it's great. New market entrants are competing for patient volumes. Mike mentioned his competition in California, probably one of the most competitive markets in the country. New entrants are competing for patient loyalty. You heard the focus that he's going to have on the front end to try to provide that frictionless experience and also make sure things are financially cleared as they go through. Self-service tools are seen as a win-win. Innovative leaders are looking for those. Patient payment, virtual intake, and others. Really, it's going to be a self-service market. I like to complain a little bit about healthcare sometimes in that it's the only place where there really are long lines, telephones, and fax machines and things. And you're starting to see places like UCSD and other organizations really understand that that's not okay and that they need to apply technology and have people kind of self-serve. Like you can book a plane ticket or a hotel reservation or an Uber. You should be able to onboard to your healthcare that way as well. This model allows you to understand where those blind spots are and understand where you can invest. It's an optimization from technology. It allows revenue and costs to be managed in a better way. Adoption of the technology designed to automate resolutions for prior auth. That's an investment that Mike is making. And platform players are enabling this transition through consolidation. It also allows you to see your footprint and where you're at. As Mike mentioned, this is a vendor agnostic, very simple tool to use, and really go use it. I think that's what Mike and I are saying. Go get it taken, go do an assessment, reach back out to us and see what we're here. And if you guys have questions, you know how to get a hold of Mike and I. Our contacts are here, and really want to thank you today. And Mike, thank you so much for spending time as we come to the top of the hour here, and appreciate your time today. Any final thoughts? Or
No, I just want to thank you for allowing me to be a part of this journey at the very early onset. And if I could ever make a plug for a tool that would definitely help make our jobs easier in a very complex world, this really is a win-win and a no-brainer. There's nothing to be lost with investing just a few minutes here. Help you level set whatever your priorities are and give you more clarity in a world that only gets murkier. So no, just honored to be a part of this from the beginning, and thanks for the opportunity.
You bet. Thank you.